Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting and we're coming to you from Meanjin, the land on which this podcast is being recorded. In this final episode of our three-part mini-series, we're again talking with Dr. Glenn Gardner, a maternal fetal medicine specialist and director of the Mater Centre for Maternal Fetal Medicine at Mater Mothers Hospitals. We've spoken about TTTS and spina bifida previously, and in this episode, we're finding out what else is happening in the maternal fetal medicine area.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Hi Glenn, welcome back to sMater.
Thank you very much for having me again.
Pregnant women with complications today have so many more treatment options compared to decades ago. Is it improved technology, or how much is technology driving those advances?
I think technology is a large part of the reason why we are where we are at with these advances, but it actually is people working with the technology. Technology alone isn't the answer. It's actually, the lot of work of many people over many years that's building on information, and then the technology has just made it happen sooner, I think.
We've talked about in previous episodes TTTS and spina bifida and that incredible in-utero surgery that you've been doing. What else, I guess, is the question? What else are you doing in this area?
Yeah, I'd be nice to share with the audience some new developments around Rhesus disease, and we call it isoimmunisation or alloimmunisation in pregnancy. And I'll just briefly describe what that is. So if a pregnant woman's blood group is of a negative type and her baby is positive, she can develop antibodies that cross the placenta and cause anemia in the baby. And that anemia can be life-threatening, or it can cause, after the baby's born, severe jaundice. And over the years, people and the audience might think, oh yeah, we've known about this for many, many years and it's old hat now. Actually, this space has been still moving with some new advances, which I will share. But actually I want to go back in time, because a lot of people don't recognise how the advances in solving the problem of Rhesus disease in pregnancy was largely driven by, a little corner of the world, Australia and New Zealand, and people that did work. And so when it was first discovered kind of in the 1930s and 40s, there was a chap, John Gorman, who ended up working in the States, an Australian doctor, and he did some studies where he solved the fact that if you give someone else's antibodies to a pregnant woman, she will not develop the disease. It'll protect her. And so that has led to our common day use of anti-D injections regularly in pregnancy for women who are Rhesus negative. So that has literally, in our country, obliterated the disease. And through that, that discovery, I'll also share how it was done. So prisoners were asked if they wanted to participate. If they were negative blood group, they were injected with positive blood. And that's how he demonstrated. Right. It's not harmful to do that to someone like a male prisoner who is not going to ever carry
consenting. Sure, yes.
Consenting, always consenting. Consenting prisoners and male prisoners, and that's how he demonstrated that. And
so where has that led to now? And
well, that has led to really largely the eradication of it, but you're never gonna solve it completely. And so cases of Rhesus disease will still come to me for treatment, and sometimes that treatment involves having to transfuse the fetus in the womb, right, in the uterus, and we do that usually as an ultrasound guided needle into the cord or into the baby's vessel in the liver, and then we have to carefully calculate how anemic is the baby, how much blood can we give, and usually we have to do it a few times during the pregnancy until the baby's mature enough to be born.
How many of those would you see? Like how common
we do
is that?
about 14 of those a year. And in fact, the first person to do that in the world was a New Zealander, Sir William Liley. And just as another little fun fact, his daughter's one of our neonatologists, Helen Liley, one of our senior neonatologists. So his name is synonymous with also an amazing kind of discovery that you can transfuse a fetus in utero. And, this is before Europe, before the States, again, Australians solving this. In Australia, we were self-sufficient in anti-D, which is the medication to prevent the disease. In 1967, we were the first country in the world we had a government-supported program to provide this medication to women who were pregnant across the country, and that fact alone, is amazing to think for our healthcare system. And then, along with the discoveries by Bill Liley of treating, once you've got the disease, you can no longer prevent it. You'll have it in every subsequent pregnancy, and that's where the transfusions come into play. Now, further to that, more recently, molecular genetics has led us to be able to test the baby's blood group just by testing a sample of the mother's blood.
Wonderful. And when would you do that? At what stage do you do that?
You can do that at around 10 to 12 weeks gestation.
Extraordinary.
Yeah. So DNA from the baby's placenta is in the mother's blood. And we can actually separate that DNA and type the baby's blood group. So if the baby is the same blood group as the mother, that baby will not be at risk. And the mother doesn't need to have those anti-D injections. If the baby is positive, those anti-D injections are necessary. So we can reduce the use of anti-D by nearly 40% by knowing the baby's blood group very early in the pregnancy. I should add that the medication, the anti-D, comes from donors, right? A dedicated pool of donors, not just any donor. The Red Cross have worked for many years to have a very dedicated pool of altruistic donors that don't get paid for this. They line up every fortnight giving their blood, and sometimes they actually have to get spiked with positive blood so their antibody levels go up. So that process is a concern for us if we're giving it to women who don't need it. So this new technology means that we will be able to reduce the use of that precious product by some 40%. And the Red Cross is working towards making that available for everyone, certainly in Queensland and hopefully in Australia. So the technology to do that test we developed between a collaboration between the Mater and the Red Cross. And then I just want to share with you one other new study that we're doing at the moment, and that is giving a medication to women who are at risk of severe Rhesus disease, and that blocks the antibody crossing the placenta. It's a phase 3 trial, which means it's placebo controlled. So I can't tell you the results or whether we will be using it in the future, but certainly it's very exciting because this is a completely new approach. And it may mean that down the track, any risks associated with transfusion are gone because all we need to do is give a medication instead.
What are the risks with the transfusion?
Every time we do a transfusion, there's a 1 to 2% risk of harm to the baby, and that might be early birth before the baby could even survive, ruptured membranes. So serious consequences. We only transfuse if we think if we don't transfuse, the baby might die. And so that risk has to be balanced against why we're doing it. But yeah, serious consequences should there be a complication of the procedure.
Can you step us through the procedure? How long does it take? What does it look like?
I'm actually doing the procedure this afternoon, so I can tell you exactly what I'll be doing.
What are your plans this afternoon then? Thank you.
So this afternoon we'll actually do the procedure in Maternal Fetal Medicine in one of our fetal therapy rooms. We don't have to go to the operating theatre. We usually give the mother some mild sedation because it's quite anxiety provoking to observe the whole thing. And we usually just do it under local anaesthetic, ultrasound guided. We have very good ultrasound equipment, as you'd imagine we would need. And we introduce the needle into the umbilical cord of the fetus. Now, depending upon the gestation, that can be straightforward, or sometimes it can be really tricky. If it's an early gestation, it's tiny and the target is tiny. We take a sample and we have someone from the blood bank who can test that in the room on the spot, and within 30 seconds tell us how anemic the baby is. We have blood bank provide us with a sample of blood that we can have ready, that we can transfuse, and then I would test again before I remove the needle to make sure that I've returned the baby's blood count to normal.
So you said this can happen a number of times through the pregnancy. Earliest and latest?
So usually the earliest is around 18 weeks, which is what I'm doing today, and it's quite much more difficult because when the cord is bigger later, it is easier. And the latest we would do it is 34 weeks. Right. So quite a broad range, and because the disease is still ongoing, you have to keep giving the baby blood, and to avoid prematurity, you really want to then deliver after 34 weeks sometime if you can.
And what would you like GPs to know about the care and the support of that woman through that time in her pregnancy?
So how we pick this up in the first place is all pregnant women in every pregnancy should have a blood group and an antibody screen done. And, I think, we rely upon the GPs to do that. And in general, without fail, they do that. And it's just to impress upon them the importance of that test, because if antibodies are found, and isn't always common Rhesus D antibodies, sometimes it's actually an unusual antibody that can also cause anemia. So if they find any antibodies, then they would refer the patient to us, and then we would decide the ongoing care plan for that pregnancy. And a bit like any of our fetal therapy patients, maintaining contact with the GP, the person that has known them longer than us and knows how, their social situation and can provide that support in the community is crucial, right up until they turn up with their baby as the GP's new patient.
Well, on that, so much interest in the work that you're doing. So we have some questions specifically from GPs for you. The first one is, how do we manage uncertainty in a pregnancy? For example, when their diagnosis or a prognosis is uncertain, how do we help patients cope with this?
Yeah, that's a really good question, but a difficult one, because I think the way to manage uncertainty is with honesty. And I think we have to be honest that uncertainty is part of kind of what we're dealing with. We don't always have the answer straight up, but the uncertainty has to be met with a desire to find answers. And if a patient knows that you're on their side and that you are going to leave no stone unturned to get answers, then I think that's how you cope. And just to kind of throw your hands in the air and say, well, we don't know, I just think is not good enough. And so information, support around what can we do, how can we get better information, how can we find out what's going on, is how I would suggest.
Letting them know you're in their corner,
Absolutely.
and doing everything you possibly can.
Yep.
Another great question from a GP. Who do I contact if I find an abnormality, MFM available outside of office hours?
Yeah, we're a bit unique here. We're one of the few sites that has a 24-hour service on every day of the year. And so I would do a 1 in 4, like all weekend, overnight with my maternal fetal medicine colleagues. And in general, it's for emergencies. And it's not usually, we wouldn't normally have people ring us up saying, oh, someone's had a scan today. That would normally be the next day, and we always are available within our service to be contacted in the daytime. But if someone is in a difficult situation, they would normally be sent to the hospital, and the first team that are on call at night seeing the patient would then contact us. Yeah,
it's great. You're so excited about, the future and what you've been talking about in the surgery and how Australia is doing so well locally. What do you think the next frontier of maternal-fetal medicine is?
Yeah, I think we're going to move away from kind of more invasive to less invasive, perhaps a more of an approach to kind of a medical, a bit like using medication to manage Rhesus disease rather than transfusions. So I think there will be a move away from that kind of invasiveness, which is great for patients and less risk. I think the molecular genetics will help us understand why things happen in the first place. And then, really, if we look far into the future, we're really looking at things like, gene therapy, modifying disease very early in pregnancy, so that the developing fetus might actually not have a condition that it was going to have.
Finally, 3 questions from me, finding out a little bit more about you as a medical professional and as a person. What was your first pet?
It was a mouse.
Actually,
mouse? Yeah, it was a little white mouse was my first pet. Yeah.
What was its name? Mousy?
Don't know, but I do remember she had babies, and that was fascinating. Yep.
Wow, there you go. Inspired you from that point. What's the biggest misconception about your job?
That we do spina bifida surgery every day of the week, or commonly. I think there's a lot of our job that probably people don't appreciate is, people coming with a risk, but actually their baby's healthy, and that's a nice part of our job, to be able to give patients good news. it's not all patients coming with difficult news.
And finally, who do you admire?
I admire, I guess, the team mostly that I work with, because everyone just pulls together to make things happen, and they all have a focus of the patient. And I think that just means, as we go forward, if it doesn't matter, if we're doing our best and we don't always have a fantastic outcome, everyone will feel that, we were in it together. And I think that team approach means that we can go forward. We do, I don't want to sound too negative. We have a lot of wins most of the time, but in our line of work, we don't save every baby. We don't always have a great outcome, and that can be heavy if you are handling that by yourself. But the team, focuses on the fact that generally working together, we're doing the best we can.
Glenn, it's so great chatting to you. Thank you for giving up your time and talking with us here on sMater.
It's been a pleasure. Thanks for having me.
And that wraps up our 3-part series with Dr. Gardner. For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in. See you next time on sMater.